Good morning, everyone. Sorry I can't be with you in Calgary today. However, I am at another meeting of the Society of Rural Physicians, so perhaps on the same topic. But anyways, I hope this video is instructive and gives you some idea of what we've been doing here at the University of Toronto and the Temi Latner Centre in the way of our educational programs for family physicians in particular and other educational programs. There are two programs I'd like to talk about that have developed from Toronto. The first is the Ministry of Health program, and the second is the Ian Anderson program. And they're really two separate and distinct programs, although we're partners in both of those programs. The Ministry of Health long-term care initiatives, palliative care initiatives, started in 1993. I co-chaired a committee of the government that had quite a number of stakeholders and developed these four initiatives, three of which are educational in nature, and one of which relates specifically to education of family physicians in palliative care. There's a total of over $1 million spent in the province over 7 regions every year in educating family physicians in the area of palliative care. And there was a set of curriculum objectives, and the original sort of idea for this program was that it would be a combination of experiential and classroom teaching that would total at least 30 hours. Now in Toronto, we are responsible for the Toronto area, York and Simcoe regions, which are the two regions north of us. And the latter two are more rural, although there's no remote locations in that area, but it is a fairly rural area, particularly the Simcoe area. Now, what we've done over the years, from 1993, we went from what was basically a 5 to 6.5 day course that was fairly comprehensive in its nature and involved only 16 physicians, and then later on about 26 physicians. We've evolved from that over the years to the last 3 years having produced a main Pro C-based course for family physicians. This is an 18-hour course that involves 6 3-hour seminars, and we have found this to be much more effective in the learning aspect of things, and we've also been able to cover many more physicians. Now, the total for the program each year is about 80 physicians, and although most of them are from Toronto, we do try to provide spaces for 20 to 30 physicians from York and Simcoe regions, and they will come from all aspects of those regions, either small towns or very small towns or rural areas. Out of a total of the 80 trainees, about 30 come from York and Simcoe regions. We've had no trouble attracting physicians at any point, but since we've made this into a main Pro C course, we traditionally get double the number of applicants for the positions, and usually we have enough applications in the first week after we send out the notice to really fill the course. So far we've done it on a basis of first come, first served, although within the rural areas we try to accept those physicians first before we go and accept other physicians from Toronto. There's very little fallout from the course. Physicians, maybe 1 or 2 out of the 80 do not come to the course, but we can easily replace them. The course was developed through feedback over the years from trainees and using the curriculum guidelines and obviously using some of our own guidelines. Each year we do a learning needs assessment for each trainee, and we work with the regional pain and symptom management coordinators in those regions to make sure that we're getting a good cross-section of physicians and that they can follow up with these physicians afterwards. The sessions are all problem-based and case-based in nature and are very flexible to learning needs. So whether you're in an inner city environment or whether you're in a rural environment, the cases are very pertinent to that. We have developed 7 modules now, and 6 of the 7 are done within the course, although we're thinking of expanding the course by another few hours. We're just starting to develop the capacity for distance learning. The Department of Family and Community Medicine here has expertise in this area, and we've gotten some money from the Ministry of Health to do this. We have a participant and a facilitator binder. The facilitator binder really guides the facilitators about the learning in each session, And the participant binder has all the educational materials, and eventually they will have all the case descriptions, etc. The problem-based modules will include things like role plays, prescriptions, homework, group work, etc. We are developing a follow-up learning program that will be part of our new website, and that still is in development, but we have some more money from the ministry next year to continue that development. The only evaluation we've done so far has been the usual satisfaction evaluation, although the reflective evaluation from the trainees for the last 3 years of the main Pro C course has been very instructive. And in fact, the evaluations are always very positive, and we do use that information to reformulate the course each year. In the early years of the program, 50% of the trainees actually went on to do much more palliative care work in their communities, but that was a very select group, and we're getting a group now that are interested in the main Pro C credits, and also a few people who are quite interested that we need to nurture in the area of palliative care. What are the lessons we've learned? Well, we need to revise and be flexible and continually sort of listen to our trainees and our facilitators. The facilitators, by the way, and I didn't mention this, are local. So in fact, these are physicians who work in those regions, and actually the course is delivered in each region. So the physicians do not have to come to Toronto for the course. We still have some difficulty in convincing the Ministry of Health about what we're doing. They still don't understand the whole issue of small group teaching, but they are pleased we've been able to increase the number of physicians going through our course 5-fold. And also there's no consistency on Ontario, although the course that we have probably resembles Pippa Hall's course and others now. I think we're all moving to the standard of problem-based learning. So that's the program as far as the Ministry of Health program. The other program that is the newer program is the Ian Anderson program in end-of-life care. We have a 5-year grant from a private individual. The grant totals $1 million. When we decided on what we wanted to do with the money, we decided on an educational program with a goal of educating 10,000 physicians in Canada around the issues in palliative care. Now that goal is quite a leap for us, and we'll probably not make it, but we keep aiming for that at least. The program is jointly managed between the Centre for Bioethics here at the University of Toronto, the Temi Latner Centre for Palliative Care at the Mount Sinai Hospital, and the continuing education part of the Faculty of Medicine here at the University of Toronto. We have a physician leader, Dr. Laura Harlock, and an admin assistant who, Laura is part-time and the admin assistant is full-time for the program. Our basic aim is to supplement and complement regional efforts, not to take over. And I think there were some misunderstandings at the beginning of the program that somehow the University of Toronto was going to come to rural Saskatchewan or Alberta and produce a series of programs. That's not what the effort is at all, and it would be impossible to do that. But what we are attempting to do is provide a standardized curriculum, a standardized set of materials, and we're also aiming at all physicians, not just family physicians, and I'll talk about that a little later on. Now the program has just started. We've had a year of ramp up. We're into our second year. The initial features or components that we've been able to accomplish so far include, the first is opinion leader conferences. We've held 3 opinion leader conferences now. The purpose of this is to give identified opinion leaders in various areas of Canada an opportunity to, first of all, learn about the Ian Anderson program, learn how they can facilitate this program, and learn how they can become opinion leaders in their area to change physician behavior and increase knowledge in the area of end-of-life care and actually make a change perhaps in the outcome of patients in the area. I mean, that's the eventual aim anyways. We have also developed a number of modules. Currently there are 11 modules. We've modeled these after the United States EPIC program. We actually have a reasonable working relationship with the EPIC program. We've used some of their materials. They're actually using or have talked about using some of our materials. That has not occurred yet, but we've been grateful for their help because it saved us a number of, saved us a lot of time and resources actually. Now all these are available on the Ian Anderson website at the University of Toronto, so if you check on the University of Toronto website and go to the Faculty of Medicine or do a search for the Ian Anderson program, the modules are there. Soon the slides pertaining to the modules will be there. The modules are designed again for problem-based learning, but in fact they could be used as a basis of lectures or other kinds of seminars. We have designed these modules with both specialists and family physicians in mind, although the initial targets are family physicians. We need to find the best approach to specialists, and this is a real challenge. Specialists in general are a hard group to find out what the best education is for them, and we need to target specific groups, and we're looking at doing that in the second year of the program. A research evaluation is being planned. We're just in the early stages of this. Obviously, it's going to require another grant to do this in an appropriate fashion. And we're definitely interested in working with any efforts of any of the group out there. So partnership is one of the things that we would like to do in this area, because I think we really do need to evaluate the education. What are the lessons we've learned so far? Well, initially people were quite threatened when there was no need to be. Putting the modules together required considerable work, but we knew that from our Ministry of Health program, and one of the problems with multiple authors is that you get very different styles, and that required a great deal of editing. We need to bring opinion leader training to people, so we need to go out into the regions, and that's the plan over this year as well, trying to stimulate interest in the regions. We talked about the specialist education and the need to this year begin that process. We were probably too ambitious to think about doing 10,000 physicians ourselves, and we're pulling back to look at opinion leader training and producing the resources and going to more of the specialist meetings as perhaps ways of getting some of the information out, and then finding people with particular interests, particularly in the specialty group, and making them into opinion leaders. As far as other areas of content for both programs, I'm developing now a module on caring for ourselves, because we recognize that physicians needed to have that kind of module that wasn't necessarily touchy-feely but also had a lot of good information in it. We also realize we need to, in all the modules, and probably in a specific module, when do you ask for help, when do you need help, how and where to seek help. That'll obviously be part of our website as well, and whether we want to go into issues like an email forum or anything like that. There's lots of those around, and we don't want to duplicate activities. We also need to make sure we have some follow-up learning, and our intention is that every person who takes either Ian Anderson training or Ministry of Health training will be contacted by email, fax, or by letter around various educational events and encouraged to take further education. We also need to find out, after we've trained people, how they can access people to provide rapid response to complex patient situations, and that I think will be handled by regional care in Ontario. So those are my comments. I hope you have a good conference, and I'm glad to at least be there as a talking head on video. Thank you very much.